Emergency echocardiography is a non-invasive, rapid, and real-time method of evaluating patients suspected of having cardiac or pericardial disease in the acute setting. The primary applications of the limited cardiac ultrasound are to evaluate cardiac function and to diagnose or exclude pericardial effusions and/or cardiac tamponade. Cardiac ultrasound is also a component of the FAST exam in the setting of known trauma. Only the primary applications of cardiac ultrasound will be covered in this video. For advanced techniques and applications, please view extended applications of emergency echocardiography. Echocardiography is often one of the more difficult ultrasound exams to learn and perform. Part of the difficulty stems from confusion over the marker dot orientation on the cardiac preset display, which is reversed from the abdominal probe presets. Standard ultrasound images done by cardiology have the marker dot on the right of the screen, whereas standard images done by radiology will have the marker dot on the left of the screen. By simply memorizing what the standard cardiac views look like on the ultrasound monitor, you can avoid confusion about which side of the monitor the marker dot correlates with. Novices can start using echocardiography by learning only 4 or 5 standard views. If the marker dot is oriented to the left of the monitor, as in the abdominal setting, cardiac images will be reversed 180 degrees on the monitor. When this occurs, simply rotate the probe 180 degrees on the patient, and this will correct the image on the monitor. The standard images shown in this tutorial have the same orientation as the images obtained in most echocardiography labs, and these are what are recognized by most cardiologists. There are 4 common probe positions, or views, used for bedside echocardiography. It is important to learn how to obtain all the common echo views because in any given patient, one view may provide excellent information while others are useless. Also, on any given patient, it is impossible to estimate which view will provide the best information. The patient should be in the left lateral semi-decubitus position, but this may not be possible in the emergent setting. The subcostal view may be the easiest to obtain in a critically ill patient who is in the supine position and cannot fully cooperate with the exam. The probe should be placed in the subcostal location with the probe marker dot pointed to the patient's left side. The probe should be aimed towards the left shoulder at a very acute angle to the patient's abdomen. The standard subcostal view uses the left lobe of the liver as a window. In this view, the right ventricle lies directly posterior and adjacent to the left lobe of the liver. The left ventricle is seen posterior to the right ventricle in this view. In the standard subcostal view, the apex of the heart is oriented towards the right side of the screen. Another view that is usually easy to obtain when the patient is in the supine position is the peristernal long axis view. The probe is placed just left of the sternum in the 3rd, 4th, or 5th intercostal spaces. The marker dot on the probe should be aimed towards the patient's right shoulder. In the standard peristernal long axis view, the left ventricle is on the left side of the monitor. The right ventricle is at the top of the screen and is usually not very prominent. The base of the left ventricle, the mitral valve, left atrium, and aortic valve and proximal aorta are also seen. The apex of the left ventricle is not visualized in the standard view. The aortic valve and root should be at the right side of the screen. The bottommost structures on the standard view should be the inferior wall of the left ventricle, the mitral valve, and the left atrium. By simply rotating the probe 90 degrees from the peristernal long axis view and aiming the marker dot towards the patient's left shoulder, the peristernal short axis views can be obtained. The peristernal short axis views are more difficult to learn and understand because 3 very different views can be obtained by tilting the probe towards the base or towards the apex of the heart. The peristernal short axis provides cross-sectional views of the heart. Standard short axis views are usually obtained at the level of the mitral valve, just below the mitral valve at the level of the papillary muscles, and at the level of the aortic valve, or the base of the heart. The last view is the apical view. As with the short axis peristernal views, several different images can be obtained by placing the probe at the apex of the heart. It is usually necessary to have the patient lying in the left lateral decubitus position in order to obtain good apical views. The easiest apical view to obtain is the four-chamber view. To obtain this view, place the probe at the point of maximal impulse, or PMI, with a marker dot aimed towards the patient's left posterior axilla. The probe should be at the apex of the left ventricle and directed towards the base of the heart, which is usually towards the patient's right shoulder. The standard view in this position will show the apex of the heart towards the top of the monitor. The left side of the heart will be on the right side of the image, and the right side of the heart will be on the left side of the image. Novices should learn to recognize the standard images and concentrate on trying to reproduce standard images when practicing the exam. Using this approach avoids confusion about which direction the probe or the marker dot should be pointed, and it is relatively easy to master the primary applications of cardiac ultrasound. The first application is the detection of pericardial effusions and/or cardiac tamponade. A pericardial effusion will usually be seen as an anechoic or black fluid collection encircling the heart. Evidence of cardiac tamponade will be diastolic collapse of any chamber in the presence of a pericardial effusion. This finding may be difficult to appreciate if the patient is tachycardic. Finding a moderate or large pericardial effusion in a patient with clinical signs of tamponade is sufficient evidence that tamponade is occurring. Other signs of tamponade are paradoxical movement of the intraventricular septum and engorgement and stiffening of the IVC. Paradoxical intraventricular movement may be difficult to appreciate, but the evaluation of the IVC is straightforward. The easiest way to evaluate the IVC is in the sagittal plane. This view is obtained by placing the probe in the subcostal space with a marker dot pointed towards the patient's feet. The proximal IVC should be measured about 2 to 3 centimeters distal to the right atrium. The AP diameter of the proximal IVC usually collapses more than 50% when the patient sniffs or during a forceful inhalation. If it collapses less than 50%, then the right-sided filling pressures and the CVP are elevated. Additional primary applications of cardiac ultrasound include evaluation of gross cardiac activity in the setting of cardiopulmonary resuscitation and in the evaluation of global left ventricular systolic function. In the setting of a pulseless patient, the lack of mechanical cardiac activity carries a grave prognosis. Other findings indicative of terminal cardiac dysfunction include global ventricular hypokinesis, absence or incomplete valve closure, and an accumulation of intracardiac hyperechoic clot. After some practice, you'll be able to detect normal and moderately depressed or severely depressed left ventricular systolic function. One method of determining left ventricular function is to assess changes in left ventricular size between diastole and systole. The ability to estimate left ventricular function is very useful in a variety of clinical settings, such as in the evaluation of patients with undifferentiated hypotension, shortness of breath, or chest pain. Estimation of relative chamber size is simple and can provide valuable information about important hemodynamic events. In patients presenting with massive pulmonary embolism, the right ventricle will be obviously enlarged with a thin wall and is often bulging into the left heart. Remember, emergency echocardiography is a non-invasive, rapid, and real-time method to provide critical information about cardiac structure and function. It should be a goal-directed examination to answer defined clinical questions. When you're getting started, focus on learning the standard views. You will quickly be able to detect pericardial effusions, cardiac tamponade, and assess global cardiac function once you have mastered these views.